All right, can you guys see my screen okay?
Yeah, we're good.
All right, awesome. Good afternoon, everyone. I will be coming up to bug all of you guys in a couple hours. But before that, we are going to go through cases from October as well as one from September. Um, and as always, any questions or concerns, please jump in and ask, and I'll happily take comments from Dr. Richards. So first of all, going through the cases this month, what is in the water in Westchester? Everyone is sick. There was so many cardiac arrests. And multiple cases where I was trying to find an appropriate GIF that would represent my face while I was reading it, but the summation of it was, what is all of this crazy pathology that we transported this month? So that was kind of fun to read, but also at the same time, holy cow. Um, the cases that I'm presenting today, pretty much all of them had excellent care done with them. Like the cases were insane, but the care was overall incredibly well done. Some of the things that I pointed out are more to try to get people to care from like great to excellent, as opposed to like trying to get it from acceptable to great. So just bear that in mind in any cases that come up, as well as some potential teaching points for people or reminders about different pathologies. I have a lot of cases today. We're probably not going to get through all of them, but we will see. And they are on a variety of topics, as opposed to my typical thing where I pick like one or two and do a deep dive. We're kind of doing a little bit of a smattering today. And then the other thing that I will put in here is there's a couple slides where my own personal experience slash thought process may be represented, which is where the double asterisks are from. I'll happily take comments from Dr. Richards or anyone else on those, but at least wanted to point some of those out ahead of time. And some of those are areas where the research is still trying to give an accurate representation of reality, where there's studies that are underpowered. So we'll talk about some of those. And because I now have a fluff baby, here's your dog therapy. This is Biscuit. He is my new doggo, and I will happily show pictures to anyone. He was a bat for Halloween, so here's your little Halloween reminder as well, as a bat dog. So first case we got is a baby on the floor. The dispatch for this patient was for a young woman who was possibly in labor. And on our arrival, they found that the patient had already delivered and the infant was lying on the ground next to the patient. Patient still had the cord attached to the baby. And the patient was overall in some pain and a little bit of distress, and the baby wasn't doing a whole lot. There was a language barrier with this as well. Um, the providers in this case did a lot of really good assessment, wrote down here some of the big things we would care about, including like assessing the baby that had been delivered. And they discussed that they appropriately clamped and cut the cord. And when they picked the baby up, they stimulated the baby, suctioned them, and baby started to wake up and cry. And they also point out that the arms and legs are still blue, but the rest of the patient's, the baby's color improved substantially. Um, then the other thing they talk about is giving the baby back to mom for skin to skin contact, as well as to help keep baby warm, and getting vascular access on mom. And then mom and baby were taken to Westchester Hospital and went to L&D, where they then were able to take care of our all nightmares. So I will be the first to admit that pre-hospital precipitous delivery is one of the things that is actually one of my nightmare fuel cases. So I try to spend some time looking into it. The in precipitous delivery, one of the things that I do think is worth mentioning for people, apologies for the typo there, and I thought that the providers did a good job describing this, is your assessment of the infant. We use APGAR scores in the hospital setting. Some of this we end up still assessing and documenting without actually calling it an APGAR, which is completely fine. I don't think you have to actually calculate the score for these patients. If you want to, you could pull it up on your phone, but I don't know that it's worth that time on scene to do that. But I do like if at least these are considered. So in this one, they talk about the color of the baby. Baby's tone is a really big one. So floppy baby versus one that is having movement and the degree of that movement. And then also things like Is the baby like coughing, crying, angry? Those are things that we want to see in a small infant. And it's worth noting those in your documentation of your initial assessment of the baby, because then if providers go and look at that afterwards, they can figure out and calculate the exact number of APGAR afterwards. But it does give you an idea of overall how well the baby is doing. And then the other two is how fast is the baby breathing and their work of breathing, and then baby's heart rate, with above 100 being completely fine, below 100 or absent being concerning. And similarly for respirations, if baby has like a good cry that is very vigorous and seems not to be in respiratory distress, you're seeing a lot of retractions, tracheal tugging, etc. Those are more reassuring versus anything less than that, like a weak cry that sounds like a little bit like a kitten, or not breathing at all. Those tend to be more concerning. In infants, we expect that for at least the first 10 minutes of life, that their fingers and toes are going to be blue. And that is part of the process of them swapping from the circulation pattern that they have in utero to their outside world circulation like you and I have right now. And part of that is that the fingers and toes are the last ones to kind of make that switch and clear out all of that deoxygenated blood. So it's okay if baby's fingers and toes are blue. What we worry about is if baby's head is still blue and baby's core is still blue. Those are more concerning for signs of not getting enough oxygen to the critical parts of baby. And one of the things that I actually remember from my L&D discussions, and whenever I talk with L&D nurses or L&D providers, one of the first things that comes up for people is they talk about when they go to ER docs in particular, people focus on clamping and cutting the cord. From the L&D's perspective, that's not the most critical thing for baby. The very first thing you want to do is pick baby up and wrap baby up and start stimulating baby, and then cut the cord after that. And what they find is that people tend to be a little bit hyper-focused on cutting the cord. And as part of that, baby has time to get cold. And these kids are just too young to thermoregulate appropriately in the midst of them trying to change the way that their body pumps blood around their whole circulation. So if you have to pick between one or the two right away when you get there, the very first thing you want to do is get baby off the floor, which is going to be cold, or get baby wrapped, start rubbing baby, getting all of that dry, wet, gross fluid off of baby. And then you can work on cutting the cord. Even in the hospital, we'll try to wait about 90 seconds to cut the cord so that baby can get a little bit of blood back to them. So you've got a little bit of time there. So it's just one reminder that I have to tell myself whenever I have one of these precipitous deliveries come in too, because our natural inclination is to quick cut the cord so we can pull baby away from the placenta and start resuscitating baby. But you can still do that while baby's attached, and it sometimes is beneficial for them. On that route, that actually goes into some of what NRP talks about, the neonatal resuscitation protocol. And in that, one of the first things they talk about as soon as baby comes out, take a look at them and then start drying baby off, stimulating them, and suctioning out their airway just to make sure that any gunk that's in there is cleared out. And then one of the things that I like is that on NRP's algorithm, and you can pull this up pretty easily if you need it, is it actually shows you that in the first 10 minutes of life, we expect babies' SpO2 to be very poor. At minute 1 of life, we expect them to look kind of blue and purple, and their O2 sat to be between 60 and 65. By minute 10 of life, they should be close to an adult SpO2. So that is one thing that can help guide your resuscitation, is if baby, at least like if you put the O2 monitor on them and baby has signs of vigorous activity, they're crying, even if they're still hypoxic in the first 10 minutes, that's okay. We expect that just because it takes that amount of time for the shunts to close in their heart and their lungs and their blood vessels for them to go to a normal adult's hemodynamic physiology. That's also part of the reason that NRP's resuscitation focuses on if baby is not crying and you actually do have to do resuscitative things for baby. Unlike adults, they actually focus very much on the baby's airway. I did 2 weeks with NICU, which was incredibly helpful because we just run this algorithm over and over. And even in the NICU for really sick preemies that came out, they'll spend 30 seconds to a minute after they do some good stimulation, which includes like flicking the baby's foot to try to annoy them and get them to cry and be angry. They will focus on doing positive pressure breathing for baby for 30 seconds to a minute before they will go on to chest compressions. That's because they find that these kids cardiac arrest or not living yet is secondary to their respiratory system not making that switch to life outside of the womb. So they support that by giving baby breasts with a BVM to try to help force those shunts to close, force the heart to change over to this non-aqueous environment. And then after 30 seconds to a minute, if baby's still not breathing at that point, then they go into chest compressions if baby's heart rate is less than 100. So if you're ever sitting around, it's worth it to pull up and look at this algorithm because it's not something we have to do very often, thankfully. But it is one of those that if you run across it, is worth it to have looked at it ahead of time once or twice. I'll pull this out usually once a month and just glance at it to remind myself some of the process. With the biggest thing for pre-hospital providers, remembering that it's airway, 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 right after stim and clean baby off and wrap them up and keep them warm. The other thing that is worth bearing in mind is if you have a precipitous delivery is mom, of course, and the thing that's going to be dangerous for mom. And for mom, that's going to be postpartum hemorrhage. It is okay if the placenta is not coming away. In natural birth, we expect it to be about even up to 30 minutes before the placenta will detach and come out. In the hospital setting, sometimes we'll give a dose of Pitocin, or the docs will use some gentle controlled traction to try to speed that process along. But it's okay if mom hasn't necessarily delivered the placenta yet, as long as she's not actively hemorrhaging. And even if that's the case, you don't necessarily, as a pre-hospital provider, have to take the placenta out. I think that's actually in our protocol that we don't do that because of some of the complications that can happen with it. What you do want to bear in mind is mom's level of bleeding. The thing that tends to be problematic for postpartum mothers is postpartum hemorrhage. And the number one cause of it is uterine atony. So you got this muscle that has just been working a ton to try to push baby out, and now baby is out. So all of this force that was kind of keeping that muscle expanded is gone. So it just becomes floppy. It also loses some of that Pitocin and salt from the brain and from the rest of the hormonal system from mom. So it can just become floppy. The problem with that is we need that muscle to clamp down so it clots off all of those blood vessels so mom stops bleeding. So in that scenario, what the first thing that we talk about doing is uterine massage. I've got two pictures up here. The one with the green gloves, I like the best because it shows, I think, a safe massage that if mom was bleeding, you could do as a pre-hospital provider. And what you'll notice is that the one hand kind of like goes right in front of the pelvic bone, and you're squeezing the top of the uterus between your hands. You don't want to push with just on the top of the uterus, because one of the things that can happen is something called uterine inversion, and that's the picture on the left. If you push on the uterus without a second hand to keep the uterus from popping out, it actually can pop out. And I had a colleague, Marlena, who actually saw this happening, and this can cause bleeding to become significantly worse. If you see this on mom, let the hospital know, and they may advise you on trying to reduce it, because this can cause moms to bleed a ton because there's just no pressure on that uterus. So if you have to do that massage, what you're going to want to do is put that one hand right on top of the pubic bone to try to help keep that from happening by, just like this picture shows, holding that top of the uterus in place. The other things that tend to cause this is lacerations on the groin, around the vagina, around the canal, etc. Those are things that we'll take care of when they get there. If you have to put like packing in place because it's just bleeding like stink, we'll take care of it. We would rather have that than it just continue to bleed, particularly if it's arterial, which thankfully doesn't happen very often. The providers in this case did exactly the right thing where they got IV access. And then if you need to, you can give mom a bolus of fluid as well. When you're cutting the cord, try to leave it long on mom's side. It can be shorter on baby's side, and that's fine. But try to leave it nice and long on mom's side because that's what we'll actually use to try to help coax the placenta out if we need to, is that long cord. And I do know some cases where when the cord is cut too short, they lose it inside of the vaginal canal, and that can cause problems for the providers later on. And then one last thing to bear in mind and to let your receiving hospital know is mom's blood pressure. particularly moms who haven't had a lot of prenatal care. One of the things that we can see is that they may have early preeclampsia. So mom's blood pressure that's greater than 140 systolic, or a diastolic that's greater than 100, those are concerning blood pressure. So that is something to let your hospital provider know if you see those for mom. If they look like a normal blood pressure range, like less than 140, less than 100 for diastolic, they're usually okay, and we usually have a little bit of time to work. If they're greater than those, that's a risk factor for preeclampsia. And the worry with those is that mom could potentially go into eclampsia, and that's where mom seizes. So that's just one thing to bear in mind for those. If you have that happen and mom seizes, benzos tend not to work very well. So it's actually where magnesium is helpful for patients if you need to do that. And you can call any medical control and they should be able to help guide some of that recess for you. Questions on that one before we go on to the next case? Or cases, I should say.
Yeah, that's a tough one, but I mean things went very much according to plan. So really nice job on that one. The couple style points, the guys even did skin to scan, so you documented as such. You put the baby on the bare skin of mom, which goes a long way. After things kind of settle down, you have your Apgar 9. So that's a really good way and kept everyone warm. And then obviously, went to OB as well. So that's great. The only other thing that I'll make mention, piggyback in your preeclampsia comment, Dr. Tillotson, is remember we do have, at least in protocol, you guys don't carry the med yet, but at least to kind of keep out in the ether in case it comes up, is that nifedipine option, which was new this year, for pre-hospital blood pressure administration in the context of potential preeclampsia. I know you guys aren't carrying the med, but in case that conversation were to come up, just to highlight another kind of learning point that was new for this past year.
Awesome. Cool. Yeah, perfect. Thanks, Dr. Richards. And that one is an oral medication, I believe, because I think it's oral nifedipine. Is that correct, Chris?
Yeah, that's right.
Okay, perfect. All right. So next one that we have is a couple cases of difficulty breathing. Come on. So this first one, crew was dispatched with concern for difficulty breathing. And when they arrived, family members took them in to see the patient, who was noted to be somewhat in some distress, tripoding and saying that she couldn't breathe. And she had her own nasal cannula oxygen in place that was hooked up to oxygen. On arrival, discussed that she'd been having some difficulty for the last few days and had been using an inhaler. I believe this patient has a history of COPD. On their assessment, she's GCS 15, not having significant secretions, has a patent airway, really like that description of it, but was having some difficulty breathing and using accessory muscles. And I also like that description because it helps us understand how sick this patient was. And when they listen, they find some expiratory wheezing and a little bit of and some faint lung sounds, which we tend to see as things such as COPD or asthma get more severe, and we'll talk about why in a little bit. So the description of this one, including like speaking in 1 to 2 word sentences, was really well done. Excellent. So this patient, they checked a 12 lead on the patient after giving her a round of albuterol and ipratropium. And she started to get a little bit better. The 12 lead just showed sinus tachycardia, which is good. And then they put the patient on CPAP, but they had to take it off because the patient wasn't responding to it very well. During transport, they tried another round of albuterol for the patient, and then she started to get worse and wasn't as responsive. I think on this one, I was trying to find the end tidal reading for this patient, and I either missed it or I don't know if it was done. So that would be one thing just to, I'm a big advocate for any patient who's having difficulty breathing. If you can put end tidal on, it tends to give you a lot of really good information, and we'll talk about why in a bit. But got patient to Westchester Hospital, where they took over management for her and got back in service. This is another one, a little bit different, where this was an older gentleman who's complaining of difficulty breathing and was on BiPAP at home. When they got there, he's awake and alert and having some difficulty breathing as well. In this one, there was concern for potential pneumonia, and there were some family members who had COVID-19. Yay! When they assessed the patient, found that he had some diminished lung sounds, and they swapped him over to CPAP, and the patient actually got substantially better on the CPAP, including his O2 sats going from 88 up to 96. This one, they also checked a 12 lead on the patient that showed a fib, and then took the patient to Westchester, thankfully without any complications for them. And then this last one was another respiratory distress patient who was normally on oxygen at home, but then was starting to have worsening shortness of breath, another elderly female with all of the medical comorbidities. They didn't have any known sick patient with them, and the patient was denying chest pain. At that time, when they assessed the patient, they put her on CPAP, and she got a lot better with it. And then on route, they got a 12 lead for the patient that showed elevations in lead V3, V4, and V6 concerning for a STEMI. So they did a STEMI alert for the patient, and brought her to Westchester Hospital while she was still on CPAP. And patient actually got a lot better after being on CPAP. And the other thing that I noted in here was that they wanted to give the patient Solumedrol, but they weren't able to do it due to a failed IV. And then thankfully the rest of the transportation went without a hitch. So I picked these cases mostly because I actually just went over some of this recently, and I think it had some really good learning points of areas where we can potentially improve patient care, as well as discussion of some of the nuances of managing these shortness of breath patients. But first, I've got a couple slides that go through dyspnea or shortness of breath and why it is such a tricky chief complaint for us to run into. So number one, our respiratory system is an incredibly complex system that has crossover with multiple other systems in our body. It is integrally related with our cardiovascular system, as it is what does the it is what oxygenates our blood and removes a lot of waste products from it, and can be involved in changing some of the pressures in the heart if there are insults to the lungs as well. The other thing that it's intrinsically involved in is regulating our acid base. It works very much with our kidneys and with our brain to change how fast we breathe to blow off CO2, or hold on to CO2 to try to balance out our body's normal pH. So that's one of the reasons that you can have shortness of breath symptoms for patients who are having an overdose, patients who've had a bad neurologic insult where their brain's not regulating their ability to breathe. So it's a very cool system, but the downside is that shortness of breath tends to be a symptom for a ton of different pathologies for patients. Some of the big things that you can look at to try to help elucidate what is the cause for this, number one is actually time course. Primary respiratory problems tend to be either a exacerbation of a chronic condition, thinking like asthma or COPD, or they're either an exacerbation of something chronic, or they tend to be a very acute and swift onset, like a COPD or asthma exacerbation. Something that's more indolent, like over the course of several days, where they're saying like, I got progressively more short of breath over time. That actually in the literature and some of the papers that I read tends to be associated with non-primary pulmonary causes. Think infectious, cardiac, kidney problems that you're trying to compensate for. And that's because you're progressively changing the way that you breathe to try to compensate for this other insult on the body. One of the other things that can be particularly helpful is your patient's history. And I've noticed going through charts that we do a really good job checking for the critical things in this. Things like diagnoses. Do you have a history of COPD or asthma? Do you have a history of heart failure? And then other things that I thought are useful after looking through some of the literature to ask is, if they've had surgeries, so a patient who's had a trach, or who was had to have like a VATS done where they had part of their lung taken out for a history of lung cancer. Those can be helpful to give you an idea of what some of their underlying problems are. But then also if they've had something like a left heart cath, because if they've recently had a cath done of their heart, that gives you an idea that from a cardiac standpoint, they're already not doing that great. Have they had recent admissions? Patients who are admitted for pneumonia and now they're getting worse. That can raise concern for a drug-resistant pneumonia for patients, or potentially another problem with being hospitalized. And if they've had something similar to this in the past, patients who have asthma or COPD, when they get exacerbations, they tend to know what it's felt like before, so they can say, yes, this feels like my typical COPD exacerbation, maybe worse, or no, this is completely different. The time course was different. There was something different about my symptoms, etc. And then most critically of all is their medications. Inhalers really are only for primary pulmonary problems, asthma, COPD. Sometimes you can use them for like interstitial lung disease, but inhalers really are only for a lung problem specifically. They don't work for cardiac problems, and they don't tend to work for other problems in the body, such as kidney problems, etc. Similarly, if your patient has a prescription for something like Lasix or torsemide or beta blockers or blood thinners, that tends to be more of a cardiac etiology for it. So it's worth it to take a look at their medications. Or the one that I ask patients is, do you have inhalers, and how often are you supposed to take your inhaler? Some patients just have a rescue inhaler, but then there's other patients who have an inhaler that they have to take every day. And that can also give you an idea of how severe their disease is. Where someone who's just taking it if they have a flare up, like your kid with exercise-induced asthma, those tend to not be as severe. Your COPD patient who has to take inhalers twice a day and they have a rescue one that they use maybe once or twice a week, that'll tell you this is probably a sicker lung patient at baseline. And then another one that's good to ask is recent antibiotics, mostly because it'll give you an idea if there's a potential underlying infection for them. When I went through, Rosen's in particular did a really good job breaking down the different systems that can cause dyspnea for patients. And we're going to kind of briefly go through some of these. And this is what I mean when I say that the shortness of breath symptom for patients can be related to a ton of different body systems. The most common ones that we'll run into is going to be a primary pulmonary problem or a primary cardiac problem. So shortness of breath for pulmonary tends to either be involved at different parts of the airway system. Upper airway obstructions, that usually shows up with stridor for patients more so than shortness of breath. They may call it a shortness of breath, but when you listen to them, you can actually hear this really high-pitched sound, particularly on inspiration. If you're trying to discern if it's an upper airway obstruction or a lower airway obstruction, listen to their neck. I actually had a patient at Jewish who had stridor because they had Botox injected into their vocal cords yesterday. And he had paralysis of his vocal cords. So when I listened to his neck, he had terrible stridor because his vocal cords were paralyzed. But then when you listen to his lungs, those sounds were much quieter. Now, in COPD or asthma, you would expect that to be reversed because the obstruction is in their lower airways, not in their upper airways. Other things to ask patients is infectious symptoms, as pneumonia or aspiration can cause this. And then things outside the lungs, pneumothorax being the number one, and then the number two would be a pleural effusion. Either a fluid collection like pus or serous fluid we can see in cancer patients, but also blood, particularly in the setting of trauma. And then ARDS, we saw a lot more of in COVID. This is this non-cardiogenic pulmonary edema due to damage of the lung tissue itself that then causes the lung tissue to swell up and not be able to appropriately engage in gas exchange. On the cardiac side, the most common one is going to be heart failure. So heart failure either from a valve failing, patient has underlying cardiomyopathy that is now worsened. Patients who have fluid back up in their lungs, like regular pulmonary edema, or SCAPE, that is sympathetic acute crashing pulmonary edema, that is also known as flash pulmonary edema. And those tend to be much more severe. MI can cause shortness of breath, as we saw in one of the cases. That's much less common, though. Most of those patients actually present complaining of chest pain as opposed to shortness of breath. Arrhythmias can do this as well, which is why, as part of the Southwest Ohio protocol, they say that if your patient is complaining of shortness of breath, please get an EKG, because if they have a heart attack or an arrhythmia, then their shortness of breath is not a lung problem, and we need to manage that underlying cardiac problem by fixing their AFib with RVR or pacing them to fix their bradycardia, or getting them aspirin and doing a STEMI alert. And every time I read about these difficulty breathing patients, you guys did a fabulous job getting an EKG on them. So I love it. Keep it up. You guys are doing great. Another one that you can have for patients, and this is really tricky to diagnose in the pre-hospital setting without an ultrasound, I'll just be honest, is pericardial tamponade or pericarditis. And this is patients who have inflammation in the sac around their heart and or fluid inside of the sac around their heart that's pushing on their heart, so it's not able to effectively pump blood. And when that happens, it causes them to feel short of breath, sometimes chest pain with it as well. And then PE is another one, a clot that goes to the lung. This is relatively common, and usually what will happen with this is there'll be completely clear lung sounds, and they'll usually, when we get a chest x-ray, it's also clear, but then when we go take them to CT scan, there's this big clot in their lungs that's causing them to not be able to breathe effectively because part of their lung is not getting blood flow to it and is dying and not able to engage in gas exchange. If you're not sure if it's a heart or a lung problem, the three things that you want to look at is their past history, like we talked about, their meds, particularly if they're on heart medicines versus inhalers, and then getting that EKG. And I think you guys are doing a really good job with that, so keep it up. Other things to look at for patients is going to be these other three categories that I don't think we think about as much. Number one is an abdominal obstruction. So in patients who are pregnant or obese or have ascites, which is fluid in their abdomen, such as cirrhosis patients, or patients with an expanding abdominal mass, what happens is that excess stuff inside of their abdomen actually expands and then pushes up on their lungs and pushes on their diaphragm. So their diaphragm can't fully drop when they breathe. It runs into this obstruction, so it's not able to drop like it normally would, and they can't fill up their lungs as much with air. And sometimes that can get to a bad enough point that it'll actually cause respiratory failure for patients. Skipping to the bottom, infection's another one. Pneumonia is one of the most common, but then another one is epiglottitis. We see this more in kids, but I do bring it up because we're starting to see a little bit of an increase in unvaccinated patients, and that's where you see this is in kids who have not been vaccinated. With this, they'll usually have very severe stridor, as well as be sitting in that tripod position, and they're drooling because there's so much obstruction they can't swallow. And those patients tend to be much sicker and need to go to the OR to be intubated. Fever and sepsis, all of these can cause patients to be tachypnic and feel short of breath just from being febrile and being septic. And then in your patients with sickle cell disease, if they're complaining of shortness of breath or chest pain, one of the things we actually worry about is acute chest syndrome. That is a cause of infection specific to sickle cell patients. Trauma is another one. Pneumothorax we think about the most, but then also rib fractures in general can cause patients to do what we call splinting. And that's where they try to keep their lungs, their chest wall partially expanded, because moving that chest wall hurts as they move those broken ribs. And that can cause patients to be tachypnic. And unfortunately, over time, if that continues, can actually set them up for infections because they're not fully expanding and contracting their lung tissue. So there can be some stasis of secretions, air, etc. And flail chest is another. Cardiac tamponade is one that we do worry about for these patients, but then another one that you can see, particularly with severe abdominal trauma, is a ruptured diaphragm. And when that happens, the abdominal contents get pushed up into the chest, and it can cause tension physiology. There's a picture of what that x-ray looks like on the bottom. On tests, they talk about you'll hear abdominal contents in the chest wall. That may happen, that may not happen. If that doesn't, you'll probably just hear absent lung sounds there. The problem is that those abdominal contents can still push the heart and the lungs completely off to one side, and it doesn't get better with needling, doing needle decompression, unfortunately. And then the other two is going to be massive neurologic insult or shock, particularly the hemorrhagic variety. With the neurologic insult, you lose that coordinated brain activity telling you to breathe. And that can cause patients to either be completely apneic or potentially try to hyperventilate to compensate for their insult. The funkier categories are things such as a stroke, and again in the neurologic insult category, or other severe neurologic disease, something degenerative like MS, ALS, but then also muscular disorders or paralysis syndromes, things such as muscular dystrophy, patients who have Guillain-Barré, or patients who are having paralysis, say from tick paralysis, which is unfortunately something that we may see more of as tick-borne illnesses tend to creep into our area more often. The other most common one that you'll probably see is a metabolic thing. Think of patients who have DKA or other acidosis, say from severe lactic acid buildup in their body. When that happens, they'll increase their respiratory rate as well as sometimes their respiratory volume to try to blow off as much carbon dioxide as they can so they can blow off some acid to compensate for the acid building up in their body. And that's where your end tidal can be really helpful. COPD patients will tend to hold on to their CO2 due to their disease process. So their end tidal will be really high. In patients who have some metabolic problem going on, their end tidal will be really low. And that can help give you an idea if BiPAP may be helpful for your patient, or if they're not tolerating BiPAP, do I need to continue with it? If BiPAP, if their end tidal is really high and they're not tolerating BiPAP, they may be getting some CO2 narcosis, and you may need to just give them a little anxiolysis to help them tolerate the BiPAP, or I should say CPAP, excuse me, so they can tolerate that better and try to blow off their CO2. If they're not tolerating the CPAP very well, and their end tidal is like 20, they probably don't need it from a acid-base standpoint. They may still need it from work of breathing, but that can help guide how much you need to push that issue for your patients. And some of the other funky things will be things like anemia, toxin exposures, anaphylaxis. Hyperventilation tends to be a diagnosis of exclusion or anxiety. And that one, I would use caution in calling it specifically that unless you have some pretty good evidence to back that up. I found this paper out of Seattle, which was really cool, and they looked at over 4 years worth of EMS runs. And in this particular paper, they looked at the runs that were for respiratory distress, and they found that the four most common diagnoses in order were CHF, pneumonia, a COPD exacerbation, or acute respiratory failure for patients. MI was much less common. If you included the STEMIs and patients who ended up with an MI, it was about 4% total. And they figured that was mostly because those patients were presenting more so with chest pain as opposed to with shortness of breath. So if you're getting dispatched to a patient with shortness of breath, these are some of the key ones that are worth keeping in your mind for these patients, as they tend to be the most common. And then lastly, in the shortness of breath category, I did want to talk about work of breathing. Lower airway obstruction management. In kind of keeping in that vein, the lower airway problems we tend to run into, number one is pneumonia, which will be this infection in their lower airway. And typically for this, you'll see sputum production with their shortness of breath and fever. And you guys have picked this up really well in the literature, in the cases that I read, including, I believe, the first one where they talked about there wasn't a lot of sputum production, but was shortness of breath. And that can be really helpful to clue you into if this is pneumonia or something else. We found that CPAP tends not to help these patients as much, and it's mostly because there is pus that is preventing the gas exchange across their air sacs. So you can still try it, but don't be surprised if it's not going to be as beneficial for these patients. And they may need sepsis management, such as a fluid bolus, may need things like Tylenol or a sepsis alert to the receiving hospital. In the obstructive category, these are going to be things like COPD and asthma. COPD specifically is an obstructive disease where the alveoli or the air sacs, the connective tissue that creates them, gets broken down. They become what we say is overcompliant. So in these, instead of them acting like a balloon where they easily expand with air and collapse to push it out, they end up being like a grocery bag where you can breathe into it, but you have to actively push on that grocery bag to get it to push the air out. As the disease gets worse, we tend to see them building up more sputum production. They tend to have worsening shortness of breath even at baseline, and ultimately they tend to need to be on oxygen. As their disease gets worse, you'll see them using inhalers more frequently as well. In the medicine world, we have different classifications for patients with COPD. The GOLD criteria is the typical name for it. In the pre-hospital world, what I would say is if your patient's on oxygen, that tends to be a much more severely ill COPD patient. Or if they're having constant cough every day, constant sputum production, and they're having inhalers they need to use a couple times a day, those tend to be sicker COPD patients at baseline. And those measures can help clue you into how bad their disease is. Asthma is a similar lower airway obstructive process, except that it's usually from a like a hyperreactivity in the airways. These patients tend to have some other sensitivity problems, such as they have allergies, they can have eczema. And what happens is they get a trigger that causes their lower airways to constrict and not allow air to pass out of them. At the same time, they get a bunch of secretions that pool up in their airways due to them being more sensitive. And that can cause plugging of those airways, so you can't get air to go out as easily. So this is what leads them to have the CO2 retention like an asthma or like a COPD patient where they're not able to fully collapse those air sacs and push that CO2 out. So both of them end up with CO2 retention and potentially respiratory failure. So in an exacerbation for both COPD and asthma, they get a trigger. The most common one for asthma patients will be something environmental. Infectious is another one for both of them. The environmental one you can see for COPD as well. That one we tend to find that medication non-adherence maybe ekes that out a little bit more. The environmental triggers for asthma patients can be kind of anything. The one that I've run into the most common, particularly at children's, is a change in the seasons. So like when it goes from really hot to suddenly really cold, like we've had recently, that can often cause people's asthma to flare up. Another one is a cardiopulmonary insult. So patient who has a heart failure exacerbation, or a patient who has an MI, patient who gets sick with pneumonia or some other upper respiratory disease, that can cause them to go into these exacerbations. And when that happens, they have bronchospasm, so their airways start to spasm and constrict down. And both COPD and asthma patients then have an inflammation response. So you've got these airways that are constricting down, they're inflamed, and then they start to make a bunch of extra secretions that clog them up and cause them to air trap. So they're not able to fully exhale before they have to start taking their next breath. And what you can see on end tidal for these patients is start seeing their baseline marching up as they air trap if you're watching them on waveform. And that's one of the reasons waveform cap note can be really helpful for them. So if the cause of their exacerbation is them having bronchoconstriction and a bunch of inflammation and secretions in their airway, our management focuses on trying to reverse those. The first one is going to be your bronchodilators, and we all do this very well, getting them albuterol. The one that I didn't realize until I had to look this up like a year and a half ago that ends up being probably the second most important thing you can do is getting them steroids. And the sooner you get steroids on board for them, the faster you both cut down on the inflammation in their airways and you get those secretions to stop being made and dry up. What they found is that the sooner patients get steroids on board, oftentimes you can actually prevent them from having to be admitted to the hospital, or if they're admitted, you can reduce the level of care they have to be admitted to. So they'll go to the floor as opposed to going to the ICU. Duonebs have another, with the ipratropium bromide, have another bronchodilator activity to them, but they tend in the literature to find that it's not as helpful as the albuterol and the steroids. The other thing that we may need to do is what we talked about in these cases as well, is giving them PEEP or positive pressure via CPAP. So what this is pressure that's constantly blowing in their airway to help force those airways to stay open and to try to recruit the ones that have had some collapse, either due to air not getting to them or patients who have not been able to fully expand them. What that happens with that is those airways are able to stay open, and that driving pressure actually helps us do better gas exchange where oxygen gets better pushed into their lungs, as well as CO2 is able to more effectively be pulled out of the airways by stenting the airways open. For patients who need this, we put their CPAP mask on, and it's usually started between 5 and 10 millimeters of mercury. And if your patient is anxious, but they need this, so patients who have really high end tidal readings or patients who have signs of COPD or asthma exacerbation, you can give them a little whiff of Versed to help with the claustrophobia of having the mask on to make them tolerate it a little better. The recommended dose in Southwest Ohio's protocol is 1 to 2 milligrams. And you guys, I read multiple cases where people wanted to put CPAP on, but due to patients' poor mental status, they did not. So that is very well done. And the mnemonic that I tell people is if you can't participate in CPAP, then you can't wear it. So they have to be able to reach up and pull the mask off if they are having trouble. And you guys have caught that incredibly well. And once it's put on, we tell people not to remove it because they can have what we call de-recruitment. So those airways that you stent open, once you take that pressure away, they can collapse again. Pediatric asthma, I'm going to skip over for today just due to the sake of time. But it is still managed in the same way as adult patients where you're going to first work on your albuterol for them and then having a low threshold to go towards steroids. The one thing I did want to point out in steroids is there is some literature that shows that pre-hospital administration of steroids does significantly impact your patient's overall outcome. So the sooner they get those steroids on, they found that it actually can reduce not only patients having to be admitted, but like I said earlier, what level of care they need to be admitted to as well. And one nice thing about solumedrol or methylprednisolone is that you can give it IM, IV, or PO. Any of those routes are okay for adults as well as kids. So if you're having trouble getting an IV and it's a patient who they know they have COPD exacerbation, asthma, etc., it's okay to try one of those other routes to give it to your patient to try to get it on a little sooner as opposed to waiting with it. They may not like the taste of it, but getting that on board sooner than later can actually significantly improve our patients' outcomes. Questions on any of those cases before we go on to the next one?
Just one comment to keep in mind. Great summary of not all that wheezes is lung, and differential, and especially the non-invasive. Boy, if we can get them to kind of cooperate with the CPAP, then that really does stave off intubation. I'm particularly interested in that first one where you had the really bad wheezing that ended up being like respiratory arrest essentially on arrival. Um, that's a really good case. I think the differential here definitely comes into play. I was just looking here at the hospital side of things. That was a primary respiratory arrest. So that was asthma, as it turned out. While acknowledging kind of the challenges in the differential, one last kind of medication that we can do, kind of going down the whole algorithm for respiratory distress, especially if we think it's a primary pulm, is to actually give epi. So for like really bad asthma, you do have epi in your back pocket that you can give. So as we're like kind of coming into like impending respiratory distress with a bad asthmatic, give epi. The policy, so the Southwest Ohio protocols will support you doing it. They ask for basically an EpiPen is how the protocol is written. If you are so inclined and have given that and need or want to give like an IV dose as well, you can call my medical and see if they'll approve like an IV. But as you're looking at like this person is like arresting from like status asthmaticus in front of you, pop up that EpiPen or your IM administration of epinephrine, and then give your 0.3 mgs IM and see if that kind of saves you off an arrest. But she actually ended up doing really well. I'm looking at her chart now. She has actually some lingering throat issues from her time on the vent in the ICU, but aside from that, it seems like she's actually doing pretty well. So.
Yeah, the only other thing I wanted to add to this is remember, if our patients need CPAP, CPAP them inside the residence, inside the nursing home, wherever we can to get them that CPAP quickly. Everybody's heard me reiterate this time in and time out. That said, I am actively looking at another CPAP circuit that's going to make this even more feasible for us, where the line will literally just be a normal nasal cannula line that goes on the nipple of that oxygen versus a screw-in type, to make it easier for our end users as providers, to make sure we're providing the best care we can for our patients. And it runs at a way less setting. It's only 10 liters per minute versus 25. Obviously, once we were to get those, there would be thorough training on it. But just a heads up, I'm trying to do what I can in my role, to make this as feasible as we can to provide that excellent care you guys do every day.
And Jason, are those the ones with the built-in end tidal monitoring as well? Am I remembering that correctly?
Yes, it does, and it'll still have the nebulizer port as well. Everything we currently have, plus the ability to go from that 5 millimeters of mercury or centimeters of water to 10.
Awesome. Those, you showed them to me last time I was up there, and those are going to be really nice, at least taking off the cognitive load of remembering to grab your end tidal monitor, as well as like HEPA filter and getting your nebs line set up and everything. So would be great. All right. Awesome. Thank you both for those. Appreciate it. And thanks for the discussion on Epi too, Dr. Richards. For time, I think this will be kind of the last chunk of cases that we will get through. There was a lot of cardiac arrests this month. And there was a lot of them that were shockable as well. For both sake of time as well as kind of not boring everyone to death by going over multiple narratives, I did not put every single narrative that had these in the discussion or in this PowerPoint. And one of the things that Dr. Richards and Chief Whitty and I are going to chat about is seeing if there's a way that I can do what I do with Cincinnati Fire for cardiac arrest. This is actually a picture of a case I was looking at a few days ago. With their software, I can actually look at the arrest all the way through and pull out like how long their pauses were, what their compression fraction was. And I can look at every single rhythm, which is my personal favorite part, to make sure that the interpretation is correct and see like where they shocked it, etc. So we're going to see if there's a way that I can start doing that for Westchester as well, to give a lot better feedback on how we're running cardiac arrest, because the documentation shows that we're doing everything fabulous. But I think if we're going to give feedback on ways to get that better, I need to like actually look at some of that hard data. Otherwise, it's just speculation, and that's not fair or particularly helpful. So crossing fingers, we can see if we can get this going. The case I did want to talk about though, was actually one in September. And this team did a really good job. It was a patient who had was called in as a non-breather. And patient had a witness arrest, and his wife started doing CPR on the patient pretty darn quickly, which is great. Patient doesn't see a physician. I don't think he had seen a physician in years, so probably some undiagnosed cardiovascular risk factors. And patient had been feeling unwell the day prior. The crew that got there found that he was pulseless and apneic, blue, but still warm, and they started doing CPR, got the patient put on the backboard, or the back on the Lucas backboard, and swapped over to the Lucas, started ventilating the patient, showed that they were in VFib. They did one of the things that I love to see is they put the IO in the humeral head, and we'll talk about why that matters in a little bit. Gave fluids, intubated the patient successfully, and confirmed it with end tidal as well as auscultation. Started epi, got amio on board. And during the code, notice the patient was going between VFib and asystole. And one things I wonder, and this is why I would love to be able to see the records, or not see the records, see the rhythms, is if it might be fine VFib, because they can look incredibly similar. And I bet if you ask any provider, they will tell you that they've had cases where they weren't sure if it was fine VFib or asystole, just because they can look very close to each other. And with this patient, they actually ended up getting ROSC, brought the patient to Westchester with a pulse, and turned over this patient to them with the patient still alive and able to be resuscitated. Unfortunately, this patient ended up going comfort care later on in his hospital course. But the resuscitation that was done by our crew was incredibly well done. And looking through all of the arrests this month, and I think when I had them pulled out, I want to say it was closer to 10. They were all very well ran, including ones where DNR orders ended up showing up later in the arrest, and people had already done the right thing of continuing with the resuscitation until the appropriate paperwork was provided. There were multiple cases of shockable cardiac arrest. And people shocked them appropriately, got amio on board for them. I think there was even one where, with consistent shocking, they ended up transporting the patient to the hospital for further management. So overall, like, I see a lot of really great things, and my hope is that we'll be able to get some of that extra software so I can give a little bit more targeted feedback. And that way I can give some accurate thoughts on it. In just some of my other cardiac arrest review that I get to do for Cincinnati Fire, as well as looking through these, I did have a couple things I wanted to bring up. One thing that I did find, we're not doing humeral IOs for all cardiac arrest patients. We still do tibial. And I get it, because tibial is substantially easier to put in, or seems that way. The problem is that humeral is significantly faster. Arrow, who makes the IO system, actually put out a video that showed under fluoro how fast they can get fluid from that IO into the patient's right heart. And it is like in seconds that they are getting this patient's medication through that humeral IO into the patient's heart, lungs, etc. From the leg, it is longer. So there is a move to go towards using humeral IOs for arrest patients as the primary IO site, because you can get that medication to the central circulation substantially faster and guaranteed that you get it there. There's concern that in that tibial IO placement, you may actually not be able to get that blood flow up to the heart effectively. So if you have to pick one, I would say your first one should probably be try the humeral one, so that you have a really good odds of the medications that you're giving getting to where we need them to go.
Kelly, with that, say you have a patient with a high need for fluid replenishment, i.e. your super severe sepsis patient, large in stature, can't gain IV access, humeral would be preferred there as well, correct?
I would say yes, based on some of the things that I found, that just due to the likelihood of getting it to their central circulation, humeral is going to be better. Do you have thoughts on that, Chris, as well?
Yeah, if you're able to get it and that's a good route, go ahead. I mean, initiate, fluid resuscitation. I mean, like you said, like the rates really do approximate like large bore, even central catheter.
Yeah.
So, yeah.
Great question. The other thing that and this is actually one of the things that I really want to be able to look at the arrest data for, is this concept of pre-charging the monitor. And this is one of the things I get to harp on with some of my other departments. I found a paper out of resuscitation recently that they showed that pre-charging your monitor, so you're going into a pulse check, you have someone who has their hand on the pulse, and that's another person pre-charges the monitor. And then you feel on, and then you actually have that charge ready to go, so that if as soon as you go into that pulse check, you see that they're in VFib, you shock them, and you don't have to stay that long with hands off the chest. And they found that pre-charging the monitor substantially decreased the amount of time that they were in their pulse checks to that target peri-shock pause of 15 seconds or less. And that's total 15 seconds or less. I think the goal is actually maybe closer to 10. So pre-charging that monitor actually made it much easier for people to meet that goal. And in this paper, they found that they actually got better rates of ROSC for those patients because that pulse check period was much shorter. I don't know that that is something that we're doing or not, because I didn't find that in the documentation. But on your next code, this would be one thing that may actually help you get ROSC more likely for your patients, is by pre-charging that monitor so you're ready to go and you just shock them. And if you don't need it, then you just dump the charge and you start compressions again for them. The other thing, and this is where some of the double asterisks are going to come in, is this concept of your patients with refractory VFib. There was a paper that came out, I think it was in 2022, that caused a little bit of discussion in the academic community about managing refractory ventricular fibrillation patients. So patients who have been in VFib for 3 shocks or more. And in this paper, it was done in Canada in a pre-hospital setting. What they did is they took these refractory VFib patients and they looked at a couple different things for them once they got to that. One of them was called vector change. So on that, they went from so once they got to that 3rd shock, they went from anterior lateral placement of the pads to anterior posterior, which you can see in this second image on the right here, where they've got one pad that is right over the heart on the left-hand side, and then one part that is and then the posterior pad is on the back of the patient. The other thing they looked at was something called, I think it was double sequential defibrillation. So they have 2 sets of pads, one that's in that anterior posterior location, and then the other one that is in that anterior lateral, and they had 2 Zols, and they had them shocked in 1 second of each other. And the paper showed that there was some benefit to either the vector change or the double sequential. And this is where it caused some academic discussion because this study got interrupted by COVID. They were not able to continue the study to power it enough to see if the vector change or the double sequential was better overall, like which one was better than the other one. Both of them seemed to show some benefit versus just your standard defibrillation, but it wasn't powered enough, and there was concern like with crossover that you were not able to show that one was better than the other. But these were 2 other strategies that were discussed as potential options to get your patients out of VFib if in your anterior lateral distribution is not working with your pads. There was another paper that I think Dr. Calhoun pointed out where they were looking at getting mechanical capture and electrical capture in pacing patients, and they found that they had better rates when they did it in this anterior posterior distribution. So there's some thought that doing that anterior posterior distribution first might actually help get better vector in general through the heart, whether it's for pacing or if it is for defibrillation. So there's some areas that are moving towards doing that anterior posterior first, and then if you have to do a vector change, then going to anterior lateral. AirCare does this mostly out of the practicality aspect that once your patient is strapped to a cot, it is a pain in the butt to go to an anterior posterior if you've already been in anterior lateral and it's not working. Versus if you have to vector change, it's a lot easier just to slap the pads on their anterior lateral side if they're unconscious versus having to lift them and shove it on their back. So there is some thought in the pre-hospital community with a lot of caveats to that of maybe it is better to look at doing anterior posterior first for your pad placement. Or I would say if you're on your 2nd or 3rd shock and it's not working in your anterior lateral, it's probably worth considering flipping to that anterior posterior and giving that a shot for patients, particularly if you're looking at transporting them because they're still in refractory VFib. And I think this is one, there's a couple papers around the original one that I'm going to try to read into a little bit more and might have an update on next month, where people are trying to better quantify this data after the initial paper came out. The other thing is that refractory VFib is another hot topic. It's a hot topic in general in the cardiac arrest research area because these patients tend to be potentially salvageable. They tend to have an ischemia as the cause of their VFib. And if you can reverse that, or if you can put them on bypass and then get their heart fixed, they can potentially have decent neurologic outcomes. So in the pre-hospital world in general, this is one of the areas where if you're on several shocks, it is completely fine to transport them. There's some discussion that if you have a ECMO capable center, transporting them sooner is beneficial. We don't have that at Westchester right now, but it is if you're on your 2nd or 3rd shock and this seems like a potentially salvageable patient, it's completely fine to consider transporting them. Or try, like in the previous slide, try another vector for your for your shock for your patients. Some stuff that's potentially coming down the right is this discussion of like potentially doing pre-hospital ECMO for patients. Albuquerque has been trying to work on this, and there's some other areas in the country that are as well. And I think the refractory VFibs are actually some of the patients that they're doing this in. And it's kind of nuts. I got to see a lecture from their medical director about their ECMO 1 program, and they have some surgeons on call, and they've trained a couple paramedics to essentially be a first assist for the surgeons that are putting these patients on ECMO. And then their paramedics are also trained in ultrasound to help confirm placement of the ECMO cannulas in the back of an ambulance with a tent over the patient's head. So it is an insane program. It's really cool. But it is still very much in its infancy and one of the hot, kind of sexy areas of research in pre-hospital cardiac arrest. There's also discussion about potentially using pre-hospital ultrasound in this capacity for arrest patients to give you an idea of what's going on with their heart. But that is very much an area where there's a lot of work that needs to be done to see if this is beneficial. And one of the concerns that's raised about this, and it's reasonable, is that we wouldn't want that to take away from still the good cardiac arrest care, where you're focusing on maximizing hands-on chest time, shocking rhythms that can be shocked, etc. So that's some of the work that's going on. And sometimes to facilitate the placement of these devices, there's discussion that anterior posterior pad placement may be better, including with the Lucas, because if your pads get non-functional and your Lucas is in place, then you can just go to anterior lateral as opposed to having to flip the patient. So like I said, those are my double asterisk points, but some of the other upcoming discussion for potential refractory VFib.
Kelly, is Cincinnati still doing the ECPR study with you?
They are, yes.
Okay.
Yeah, so as part of that I forget the exact criteria. I think it's actually supposed to be on the Lucases, but in like younger patients who are having, they're in refractory VFib, so I want to say they're on their third shock. They can load them and take them to UC, and then we'll actually do, or UC will do like a STEM alert essentially for ECPR. And have the CPR program people come and see the patient to determine if they can crash them onto ECMO. I know there was discussion at one point about potentially doing that in the Shrew, and there are some other places in the country where when these patients hit the door, they will put them on ECMO in their trauma bay. But I don't know that we are there yet at the U, last I heard, and we're certainly not there at my shop at Jewish, and I don't think we're there yet at Westchester, but those are some things that may be coming in the future.
Has there been any successful cases out of that with Cincinnati Fire?
That I don't know for sure.
Okay.
Do you know, Richards, if they've had some success with those yet?
A good question. I feel like they have had a success story, but I know it's not like used super often. And they also went through like a period of time where they had to put the program on pause for a variety of different reasons.
Mhm.
But now that you ask that question, I don't know that we've had an update here recently on the program, to be honest.
No. I'll have to look and see because I'm curious. And like you said too, COVID, I think like a lot of other ECMO programs kind of threw some wrenches in the wheels because we just didn't have enough ECMO circuits with all the people that had COVID. But I'll have to find out for sure. Woody, do I have time for a couple more things or do we need to wrap it up?
No, I think we got a couple more minutes, like 2 more cases or something.
Okay, cool. These are I called them cardiac arrest. So these were ones where the presumed primary etiology for the arrest was not the heart having a problem. So the first one was a patient who was having significant rectal bleeding, who then ultimately went into cardiac arrest. The description that I understand from the crew was that this patient was having like substantial bleeding all over the place due to like this profound rectal bleeding. And this patient got appropriate medical care where patient went into a shockable rhythm. He was shocked. Airway was managed with an eye gel. Patient had, I want to say it was IOs in the tibia that were placed, ran ACLS algorithm, things were done appropriately, and patient was transported to Westchester with concern for hemorrhage as the etiology for this patient's shock, which I think was an appropriate move for this patient. The other case that I thought would be worth just a brief discussion on was another weird one, where the call was for a choking patient, but when the crew arrived, it was a patient who had had a tree fall on him. And the patient was stuck under the tree with significant head trauma from the tree landing on his head. I did appreciate that the crew put a good description of the severity of the injury with exposed brain matter, sunken skull, some proptosis of the eyes, etc., just to help understand the severity of the head trauma. And then, of course, this patient was in arrest before our group got there, having CPR done by Westchester Police, and then that was taken over by our crew. The case focused on airway management for this patient, so a BVM was used, and then had IOs put in. Patient ultimately had an eye gel put in. I don't think attempt was made to intubate this patient, and then they controlled bleeding, and worked on taking the patient to the hospital. So I think the things that I wanted to focus on in these cases was discussion of non-cardiac causes / more traumatic causes of cardiac arrest. And the main reason I bring that up is that in this case, was anything we do necessarily going to change anything? Probably not, but I did want to use it as a reminder of the cardiac arrest, the traumatic arrest algorithm, and why we do it for patients. So traumatic arrests are arrests that are more caused by non primary cardiac, so MI, STEMI, etc. causes. Those tend to fall in these buckets of massive hemorrhage, severe obstructive shock from a pneumothorax or pericardial tamponade, massive neurologic insult, or medical problem that caused them to arrest. So think hypoglycemia, an MI, or a seizure that a patient had while they were driving their car and they crashed it into a tree. And now they've had an arrest, but it was because they had a medical problem first. The most common ones you look in the literature is going to be blood loss number 1, obstructive shock number 2, and then massive neurologic insult number 3. So severe C-spine injury tends to be it, or severe head trauma, like in this first patient. I am a big advocate for using the March algorithm when you're evaluating a trauma patient in general, but I like it a lot for cardiac arrest patients as well. Because I think or traumatic arrest patients, I should say, because I think it helps us remember in order the things that are going to kill this patient, with massive hemorrhage being the first one. Airway is your second category, so making sure they can breathe. Respirations, what I think of in that category is, do they have a big pneumo? And then circulation for them, getting them circulatory support with an IV and fluid bolus. And then H at the end is going to be, I teach it the way that Hinckley does, where it's 3 H's. It's head, so head trauma, head and neck, hypothermia, and then hypoglycemia. With head being that neurologic insult, hypothermia as a reminder that we need to keep these patients warm, because these trauma patients tend to get cold and then they get coagulopathic and then they bleed more no matter what we do. And then hypoglycemia is a reminder that there may be a medical cause, like an MI in particular, is one we can take care of that caused them to have this arrest in the first place. So when you're managing these patients, if you use the March algorithm for a traumatic arrest patient, it'll walk you through what you need to do. First, walk up to your patient, make sure there's no massive bleeding, and if there is, wrap it right away, put a tourniquet on. I put pelvic binders in this category for the appropriate patient, so ones that have been in a bad car crash or a bad fall and you're worried they may have an open book pelvis, just put the pelvic binder on. Because what I found is, including in reading multiple notes from even physicians that are in the field, everyone forgets the pelvic binder. So that's why I've started thinking it for myself that it is in that massive hemorrhage category. Make sure their airway secured, and then make sure you take care of a pneumothorax with your double needle decompression. Get access quickly, either give them blood or fluid, and then make sure that you're protecting a C-spine, and then making sure that they are warmed, and then evaluating for that potential medical cause. This March algorithm, they actually validated in the military. And what's kind of fun is there is actually a journal for special operations medicine. And they showed that teaching paramedics in particular this March algorithm, they were able to very effectively go through it and take care of a lot of address severe causes of cardiac arrest or traumatic cardiac arrest very quickly. And it was an easy one to remember as opposed to some of the other mnemonics we come up with. And then the other thing I wanted to bring up is I taught this to CFD in the context of an isolated GSW, but it's really isolated head trauma. Isolated head trauma is not necessarily incompatible with life. So I'm glad that in the case with the severe severe head trauma patient that they were transported, that was very much the right thing to do. The question comes up is that because it's severe head trauma, it's probably incompatible with life. And most people in the trauma world, if you talk to them, they probably have at least one case where the patient had a really nasty isolated head trauma, but they ended up living. And some of them ended up living neurologically relatively intact. I had a co-resident who had that actually happen. So just because it's isolated head trauma doesn't mean that it's necessarily going to 100% kill the patient. Part of that is due to the severity of the trauma. This patient with their crushed head, the odds are not good for them. But in a ballistic isolated head trauma, it depends on where that ballistic projectile goes and what it goes through. If it's one hemisphere, you can actually have sometimes good neurologic outcome for those patients. If it's transtentorial, that tends to be more severe, like the picture on the bottom left, because you disrupt the venous structure of the brain, and that's what causes problems. They're just not able to drain blood effectively out of their brain. And the outcome for, sorry, the study's cut off, but I have it linked in the resources for this as well. The outcome for isolated GSWs tends to be really poor. Or even just this was isolated GSW study. I think the East guidelines people put together, the East trauma authors, and they looked at multiple years worth of isolated GSWs and found that survival to discharge was pretty low. But isolated head trauma patients ended up being good organ donors, so potentially able to help somebody else, unfortunately, through their misfortune. So as part of Southwest Ohio's protocol, it does say that penetrating isolated head trauma, particularly isolated penetrating head trauma, is not incompatible with life. And we should still go through the management for traumatic arrest. So still doing needle decompression, still getting them access, etc. The one that I find gets missed the most on my chart reviews for CFD is the needle decompression. And it's because people think it's isolated head trauma. So it's probably not going to cause problems with their lungs. The problem is that you can't necessarily confirm that in the field. It's hard to do. Most people will have a story of where it looked like it was isolated head trauma, particularly a GSW, and then they found out that there was actually a second bullet wound. Or say in this patient, the thing I would worry about is if when they got crushed, that force was enough to fracture ribs, causing a pneumothorax with it as well. So it is still worth it to do those bilateral needle decompressions. If for nothing else, it gives us practice to do that procedure so we become more facile with it. And then you've had a rep with it on well ahead of time for a patient that might actually significantly benefit from it. The risk of doing it versus the potential benefit is also really low. So between getting an extra rep in it potentially being beneficial, it's worth doing. And if there's questions about if any of this is worthwhile or next steps, it is still, I still am always an advocate for discussing with med control. But in general, if you have someone who has this potential other etiology like isolated head trauma, go ahead and just do the needle decompressions as well as the other components of the traumatic arrest algorithm. And then it's just taken care of and done. And you've had practice with it before having a patient who potentially could benefit from it. I think that's last ones I have on that topic. Other thoughts, questions on that? I know we're running out of time.
No, I don't think there's any other questions for me. Do any of the companies have any questions for Dr. Tillotson?
No. Nope. Nope, we're all good.
Awesome. Kelly, do you want to throw the other cases? Because we had a lot of tremendous cases this month. Do you want to throw the other cases into the beginning of next month?
Yeah, I think I will. And there are a couple ones I needed to dig into a little bit more, which is why they're at the end anyway. So yeah, we'll go over those next month. Unless more craziness happens in the next few weeks.
I'm sure there's bound to be.
Oh, there will.
Well, thank you very much. We really appreciate it.
Yep, thank you. I'm gonna go ahead and stop the recording.